Thank you so much, Professor Marian. My sincere thanks, and to Simona, whom I see there. Greetings from India, and thank you so much for having me on board this conference, because I was a little overwhelmed when you invited me to speak, because the whole concept of biologic dentistry and sustainability was something which took a little while for me to sort of understand. And I think Dr. Simona will bear me out that I did touch on this briefly when I was lecturing at a university. I think it's an interesting time, and we are at a crisis in oral health sciences, because we seem to have moved away from overall systemic health, and we seem to have become technique focused. And that's been a concern for me 40 years down in the profession. I think, if I may reflect, the tooth paradigm has been centric to dentistry. And this has become more so because every day you see these advertisements, and you see the various manufacturers coming at you and telling you, this is the best material to fix a tooth, this is the best material to straighten teeth. And then they give you a cookbook solution that, if you do this, voila, you'll have a beautiful smile and a great practice. I think it's a big tragedy, because it's only in 1940s that the World Health Organization proposed a larger definition of health, which was not just the absence of disease, but well-being and quality of life. Now, oral health is directly related to well-being and quality of life. And my concern is that who forgot the patient? There's this whole obsession of fixing broken, decayed teeth. Do you fix the teeth, or do you fix a patient with broken, decayed teeth? Now, this is a huge challenge, and it becomes even more difficult when you start talking to students who don't seem to understand. When you look back, I think the largest problem in dentistry and orthodontics, which is my specialty by extension, has been the imperfect information available. Now, if you look at the 1920s, there was a paucity of scientific understanding, with very little knowledge about, say, dentofacial deformities. There were some thoughts on internal secretion, habits, breathing, heredity, but that was it. If you look at medicine or systemic health science, it only changed in the 40s, because before that, you had a placebo, or you bled patients, or you purged them, and they died in the process. I think we stand at a juncture where for all the understanding of science, biology, heredity, and genetics, we have reverted to the system of treating teeth and not the person. This is my concern. And I think this is where we need to redefine a new perspective. And I really appreciate the initiative about biologic and sustainable dentistry, because Hippocrates said that it's far more important to know what person the disease has than what disease the person has. Which brings me to my topic, of today, which is about the silent epidemic. And the tragedy is that this has been unfolding right beneath our eyes. And as a profession, we were in the forefront of diagnosing or even observing it. It's a common disorder, let's be honest. It may be symptomatic or asymptomatic, but it has major neurocognitive and cardiovascular sequelae. And I think the biggest tragedy is that people laugh it off, and even the most cases of OSA remain undiagnosed or untreated. I think there are two issues here. One is the lack of awareness on the part of those who have it, and of course, the professionals who are involved, because it's something that is not mainstream or promotable by a company, so it doesn't hit the limelight. But let me just tell you the huge burden. In 2015, the cost of diagnosing and treating OSA in the US was $12.5 billion. And this is not just it, because I started looking at the global prevalences, and the first set of global prevalence estimates suggests that 1 billion adults between the age of 35 to 69 suffer from obstructive sleep apnea. The numbers with moderate to severe OSA, which require treatment, is roughly 425 million. And I think the numbers grow because I can't comment about your countries, but let's look at India, where diabetes today is an epidemic in itself. The increasing burden of non-communicable diseases, obesity, the BMI and age, this is added to the global prevalence of the obstructive sleep apnea, which tragically, as dentists and orthodontists, we were in the front to diagnose and treat. And this I've quoted from the Lancet Respiratory Medicine Journal. These are the global figures, friends. You may have a look, you may look at your countries, and you may see what is the map. And this heat map shows you where the prevalence of sleep apneas is beginning to pick up. And you will understand why I called it the silent epidemic, because it afflicts the world. We are not even aware of it. And yet, very little is done to treat it or to sort it out. It's a lovely book. I think Dr. Sandra Khan is speaking subsequently in this conference, but this was a great book which sort of touched the fringes of this. And it's written very openly that OSA is on the rise. 20% are diagnosed with it. And 50% of all cardiac patients have a comorbidity. And there are lots of things that happen to children. And somehow, it's not been treated as something that needs to be taken care of. And it's somehow got connected to small jaws, malpositioned teeth, increasing patients wanting straight teeth. And there's a whole link that comes up when you start looking at it. But the same book quotes that a Swedish study has suggested a causative connection with cerebrovascular disease, coronary artery disease, and a lot of deaths that happen in the nighttime. But my concern when I started looking at this about, maybe 10 years back, is that we've gotten to the profession of straightening, restoring, replacing teeth, building occlusions without a real thought to the health issue that lies behind the altered facial form and function. And that's what it's something that one needs to focus. So let's see, how did this come about? It's very interesting, because roughly 3.8 billion years ago, certain molecules combined and to form a complex structure called organisms. And about 2.5 million years ago, Homo erectus, or the erect human, was found in East Africa. Now, that's simple. But what happened was that the transition from Homo erectus to Homo sapiens brought about changes that were radical. You see, because when you walked upright, you had to look above the grass, you wanted to search for your foods, and you wanted to free your hands for many roles, but it came at a price. And that was the price, was the beginning of this epidemic, because the scaffolding had to take up the weight of the head, right? And the brain posture became an issue. The larynx descended, as these images from the same book and others show you on the right side. And that was one part of the story. And then we decided that, we wanted to do away with finger gestures, and language came about. The ability to communicate verbally brought about significant changes, because if the tongue rested completely within the jaws, it wouldn't impede the airway, like on the left-hand side when you see the this figure here, that it doesn't impede the airway. But then you can't speak, because how does phonation take place? Because it's the tongue that's going to bring the vibrations and let you speak to each other. So this was in the making. Let's put it like this. And then, of course, to add to it, you discovered fire, which led to cook diets. And you started settling into a civilization where you spoke to each other, and then the developmental growth got affected. And so you started looking at faces which were so synonymous with mouth breathing, right? This has been a concern. We've spoken about it in the specialty of orthodontics for many years. And I think this is something that we needed to think about. We knew about it. We've done functional appliances, but somehow we just forgot that this should have been mainstream at the back of every case that you assess, because mandibular position is closely related to airway dynamics. And which is the only profession which is in the forefront of diagnosing a sleep apnea or looking at it or even communicating it's dentistry and then orthodontics, because you are assessing it, evaluating it on a day-to-day basis. And then you went through this phase of, extractions, retractions. And if you didn't think about the biologic and the physiologic effects, you had serious issues. Let's say take this further, because dental sleep medicine came into being, and we've been sort of now pushing the idea of airway-centric orthodontics, because which is the only profession which can manipulate the movable parts of the craniofacial skeleton to bring about some changes in the airway, and that's your and my profession here. I mean, literally, if you just reposition the jaw forward by a few millimeters, you would create more room at the back of the mouth for tissue patency or firmness with less collapses, and things would happen. But somehow this has evaded us. So let me just clarify, because we've been now talking and writing, we published a lot into this, that what's dental sleep medicine now? It's not sleep dentistry, please. Because I've had this question coming at me from audiences around the world. Prof, is it sleep dentistry? No. Sleep dentistry refers to sedation in order to perform dental work. But what dental sleep medicine is, it's a branch of dentistry that focuses on the craniofacial and physiological connection between sleep breathing disorders. And how do they manifest? It's snoring, it's upper airway resistance syndrome, bruxism, and these are the chief concerns for a dentist or an orthodontist who are at the chair side to identify risk factors for these sleep disorders. And yet, we've not taught it, we've never spoken about it. So what is the point that I'm making? That we need to be the frontline screeners for potential OSA. And we see more patients than doctors do, because you have dentistry which may be requiring sort of either symptomatic or asymptomatic dentistry. People do go to dentists. And it becomes our responsibility to make sure that you look at a patient, you at least keep the thought in your mind that behind the obvious dental problem that he's come for, there is a biologic or a systemic health issue that is manifesting itself. If you know what to look for, you will find it. And I've discussed it, I've spoken with primary care physicians. They're not tuned to the quiet signs of untreated obstructive sleep apnea, like headaches, large tongues, thick necks, soft chins, narrow arches or airways, and a complaint of low energy, insomnia, or depression, which hits the patient who comes to you. Let me tell you the story of a young businessman who got referred to me after having been everywhere. And I show you his panograph. You can see his failed orthodontic treatment. He's had extractions. Somebody's retracted his incisors. He was very successful. And he was very, very conscious that he doesn't want this to get out, in my discussion with him. That's a CBCT to show you what damage incomplete or poor orthodontics can do. But I think more than that, the reason he came to see me was that there was a prominence of roots, because somebody had retracted his teeth without bothering how they tipped back. And he had pain in the spaces that were left in orthodontics. So this was the obvious note that I got from the referring dentist. But when I sat down and spoke with him, the whole issue was something different, completely different, because I will lead you through this to show you that just look at this airway space, which is completely obstructed. You can see it here. And here you can make out that there was a serious issue. And here we were looking at something. He used to sleepwalk, and he had serious issues, and he was very conscious. He had in-depth analysis in psychiatric analysis. His family took him everywhere, but they never, ever thought that he had a choking sensation. He snored, they should look at it. And I want you to just look at the Hoyt bone position, the proximity here, and the posterior, the middle pharyngeal airway, which is completely obliterated. So here was a challenge, that how do you treat somebody like this? His first request was no photographs. So I'm not showing you photographs, but this is what we did. we found, because luckily by then we were screening everybody. And if you take the Epworth sleepiness scale, I'll talk about it later, he had a score of 22, suggested of moderate to severe obstructive sleep apnea. There was a complete compromise on the middle and lower pharyngeal airway. A polysomnographic study showed an apnea-hypopnea index of 49, which is severe. So what I did was I started him straight away on a CPAP, and then we started to build the occlusion, corrected the overjet, leveled the occlusion to let me give him an oral appliance to sleep with. Well, he's a lot better. He's back to normal. So this is the kind of issue where we found ourselves challenged. And I think it's a lack of information. It's also a perception of the whole aspect of snoring, which families tend to laugh at. The patient himself is going to say, oh, yes, I snore. My wife tells me she'll kill me. But there is a problem that has separated the reality from what exists at the back. And I'll be honest with you, because I really appreciate this whole sort of initiative in biological dentistry, because the tooth syndrome, and I made that point right at the beginning, it's isolated the oral health professional from mainstream healthcare, where you need to work with physicians, pulmonologists, ENT specialists, and they are not even, aware of the possibilities of diagnostics and the interventions and the benefits of oral appliance therapy, or even CPAP with craniofacial manipulation, which we've done forever. At least in orthodontics for 100 years, we've moved mandibles, we've expanded the upper jaw, we've held it forward, but we never realized that what we were doing probably was a much larger service to the patient than anywhere else. So what is the challenge, and how do I define a perspective? I think first is an advocacy and interaction with the healthcare professionals. I needed to convince physicians, pulmonologists, ENT, non-communicable disease specialists that, listen, just send the patient. If he wakes up, he's tired, it's maybe just a little more. We realized cross-referrals, but even in a hospital practice where I do, it was very difficult because the ENT would treat him separately. The pulmonologist would say, all I can give you is a CPAP, and he wouldn't look at it. So I think surveillance is a must. And I think that's where it brings us to the fact that I think for dental professionals and for orthodontists, I think we have a primary responsibility in screening this in all patients that you see. So what is the story? Well, everybody snores, right? And if 40% of middle-aged adults snore, about 20% would need treatment. And everybody who snores doesn't have a problem, right? But here you are now looking at an issue of childhood obesity. About 5% of the population, pediatric population, needs intervention. And this is linked to junk food and obesity, which is coming. And I think this is the challenge for us. We are in a position to diagnose, modify, and influence the airway. And I think for any orthodontist, it should be centric to any diagnosis and treatment planning in the orthodontic domain. So how do we connect the dots? We can't do a randomized controlled trial because you can't say that one group of people who snore would be given an appliance and the others who wouldn't. It's this famous story which was put. I mean, I've been involved with evidence-based healthcare, and I got this tongue-in-cheek story of the shortfalls of a randomized controlled trial, which was about the parachutes used to prevent death and major trauma in air accidents. And they wanted 50% of people to jump with a parachute and 50 without a parachute. It's tongue-in-cheek, something that the Brits do very well in England. But that's the point, that the issue is that you're now looking at real-world evidence. 50% of people would snore, 16 would show signs of daytime sleepiness, 11% of this would have an established sleep apnea. And the health impact is exponential in adults and in children. So here is what happened to me in the last decade, because I said, I'm just stupid. I do stupid things, but then I'm ignorant by choice, and I learn bumbling around. And I'm so grateful I've got this opportunity to share my thoughts with you. The simple question for any patient who walks into your practice is, did you sleep well tonight, at night? And you'll be surprised at the answers you get. Okay. So what do we know about sleep? As I said, I've taught orthodontics for 4 decades. And how much do we talk to our residents or even on the floor of a postgraduate clinic? I think the first issue when you're looking at dental sleep medicine or airway-centric orthodontics or obstructive sleep apnea is to understand sleep. About 1/3 of your lifetime is spent sleeping. And yet there's so little we know about sleep. The orthodontists, we take histories, but I don't think we've ever asked the patient, did you sleep well last night? And if you did, if you're not, are you tired this morning? But then this has existed in the ancient Indian and Egyptian texts. Hippocrates wrote about it, but sleep knowledge only developed in the last 3 to 4 decades, and that's something that we all need. Sleep characteristics tend to stabilize around 20 years of age, and sleep differentiation is highly individualized. It's normal for children to take bedtime naps up to 5 years of age, but if this extends further during the day, it might mean the child is not getting enough sleep at night. Older people spend more time in bed, but then their sleep requirements are similar to that of children. So what is sleep architecture? This is the first thing, as I said, I was stupid when I started working with my colleagues, and I said, I had to learn this. But sleep architecture and your sleep cycles define how you sleep. And there are 2 types of sleep. One is rapid eye movement, and the second is non-rapid eye movement. The non-REM sleep is broken into 3 stages, N1, N2, N3. And you have to understand when you're talking to a patient at what stage is the patient going through a break in the cycle. And this is what it is. N1 is usually after, you've just fallen asleep and you're not in full sleep. It's a shallow sleep. When you're in stage 1, your brain is beginning to sort of give you bursts of activity. And out of the total time that you sleep, it's about 2 to 5% of the total sleep time. Okay. N2. This is when you are moving towards a deeper sleep. Okay. It's 5 to 15 minutes after you go to bed, your body temperature drops, your heart rate slows, and we become disengaged from the environment. And half our nights are spent in stage 2 sleep. And then, of course, N3 is the deep sleep, when the body releases the growth hormones, the bloodstream, which moves the cells to repair. This is what replenishes and refurbishes your body. Now, you can imagine that if your sleep is disturbed for you, and especially for a growing child, and you don't get to N3 sleep, how is your body going to restore itself? How is it going to repair itself? Right? This is your big challenge. And this is where this whole concept of being awareness about sleep and the obstructive sleep apnea comes into play. This is rapid eye movement. You've all heard about it. And this is the deepest sleep. This is the time when you dream. It's accompanied by a muscular paralysis below the chin, and it's about a quarter of the night at this stage. If you don't get to REM sleep, you are extremely tired in the morning and you will not be able to function well. Your mental acuity suffers. So this is what the whole process of sleep architecture is. And I say this to you because I hope to arouse interest in this audience and to my colleagues to read about it, to look at home, how it happens. So this is where the cycles of sleep tend to define. And if there's a disturbance, what happens? What are the consequences? So if you're healthy and you enjoy good quality sleep, you can have 4 to 5 cycles of sleep, right? Brief awakenings are normal. But what happens if you do not sleep that well? And I think the first thing that comes up is about snoring. And there is a huge ignorance, misperception, and misinformation. A person could be dying of snoring, and if it's a husband and wife, they will tend to suppress it and laugh about it, but not tell you. Now, this is the serious. So do you snore? This is a simple question because 25% of adults snore and 24% are sleeping in separate beds. 2 in 5 couples openly accept that snoring is affecting their normal lives, and 60% agree that lack of sleep is ruining their relationships. And that's the reality of snoring. It's a silent, pun intended, killer of relationships. It deteriorates the quality of your life. And yet, when you ask a patient, do you snore? He's going to laugh it off. His family who accompanies him is going to laugh it off and say, oh, yeah, he snores, but you know how it is. I put a pillow on his face and I say, listen, you may be killing him. He might not live long enough for you to take this. That's where you start looking at obstructive sleep apnea, in which you will find that the person who has an undiagnosed OSA will gasp for air, make no noises, then begin to choke, clear the airway, sit up. There are anatomical problems. As you grow older, you have a floppy airway, right? You sleep flat on the back. There are conditions of snoring, obesity, lifestyle habits. You drink too much, the floppiness is going to increase in your posterior airway, and you're going to have problems. So this is where the challenge comes, and you need to look at it. Because I think snoring has to be viewed as a warning sign or a risk factor for obstructing sleep apnea. Well, that's how you breathe normally. If you look at the animation on the right-hand side, but as the sleep gets deeper, there's floppiness, the tongue tends to fall back, and that's where airway resistance increases and everything begins to vibrate, and you get variable noises, and this creates a serious issue for you. So this is the challenge of sleep disordered sleep breathing, because everybody who snores may not have sleep apnea. Snoring may be mild to moderate. It leads to upper airway resistance syndrome, which may have health effects. You go to obstructive sleep apnea, where you definitely have effects. It's going to present itself between 40 to 60 years of age. This is stats show, but as I said, the pediatric sleep apneas are picking up. Almost 1 to 2% of the population is beginning to show issues, right? It afflicts males more than females, and it's about 9% of the adult female population. And 1/3 of those with OSA are serious enough to start treatment immediately, right? So here is the challenge. How do you identify obstructive sleep apnea, or how do you start practicing dental sleep medicine in your practices? It's very easy. It's a simple set of questions. A family history, obesity, neck size larger than 17 inches. If you're a male, you have a simple dentofacial deformity like a narrow palate or a classic sort of a lower jaw, which is leaning back, well, you need to ask the questions. And for us, I think the easiest is, and which we implemented even at the institute and the private practices, that you have something called this Epworth Sleepiness Scale. It's available free on cost, and it's online, and it's a simple tool where you get the patient to fill in. You fill in a score. If it's under 10, you're fine. If it's 10 to 16, you may be having a problem. 16 plus means you definitely need to investigate for obstructive sleep apnea, right? This is what we introduce in the outpatient departments. All patients are screened, even at the institute. That Professor Sam, if he's here, he's been to us, but we started a sleep clinic at Cool. And this is where the questions that are asked are very simple and straight away. And this leads to your looking whether you need to investigate it further. People with obvious issues need to be questioned about their sort of sleep habits, what happens to them, right? We also had something called a stop bank questionnaire. We looked at 400 patients, and, that's the breakdown. And just to show you that, almost 32% snored, 23% were tired during the day, right? Has anybody seen you stop breathing at night or witnessed you when you're asleep? 11% said yes. 17% had blood pressure. And here's about the BMI and the age. So also, I think for dentists and for orthodontists, I think there is a very simple thing about facial morphology and facial characteristics, which are very, very distinct in cases of obstructive sleep apnea. A long, narrow face, retrognathic mandible, dark circles around the eyes. You get a clear image. You have an obese patient, difficulty in walking into the clinic. Every patient will have a story to tell, whether he's a child or an adult. right? So this is what I told people. You need a clinical examination which goes beyond teeth or orthodontics. At the first level, you take a simple feedback response on a scale like Epworth or Stop Bang. You just look at the height, weight, BMI index, neck size. You look at the nose, the septum, turbinates. You look at the palate. You look at the uvula. Can you see the tonsils? The Malapati syndrome, I mean, scale is so easy, which will give you a very, very, very clear idea whether the patient is likely to suffer or not likely to suffer. It's something very simple which needs to be taught. I mean, class 1, class 2, class 3. If you're somewhere between class 2 and class 4, you can expect things to happen. This is how your tongue size and your tonsils can tell you a lot. For orthodontists, it's very clear that you have a narrow V-shaped maxillary arch, you have a crowding, and you have a jaw which is hanging down, which is falling back, and you have a very, very seized. Now, there is a direct correlation of obstructive sleep apnea with facial morphology. And for the orthodontists who are watching this is what comes out, very, very clearly, that this is what you're likely to see. There would be definitive craniofacial features for people with obstructive sleep apnea. And you need to look for them, and you need to understand that you will like to do it. And these are some very characteristic issues which anybody can observe. Doesn't need sort of rocket science to see who's going to suffer from this and who's not. This is a book we published. We came up with a very simple way of looking at a cephalometric analysis, a 2D analysis, which which could give you an idea. And remember, the position of the white bone is very, very important in terms of understanding what happens. The distance between the white bone and the mandibular plane angle is longer in OSA. And this relates to collapsibility of the pharynx. And this is an indicator of obstructive sleep apnea, the white bone position. And I'm not talking of fancy diagnostics. We are talking about a simple two-dimensional cephalogram, which shows you, because you can observe all this if you're looking for it. But the only way the challenge comes is that to establish whether you have a clinically relevant sleep apnea, you need a polysomnogram. And this is probably a challenge because a lot of patients are not comfortable with it. And this is where your costs escalate. But what we've noticed is that over a period of time, if people are convinced that they will have issues and they need to take care of it, then I think domiciliary or a polysomnography at home, we have people who come and put the monitors, take them away the next morning, and then you get an analysis which tells you very clearly that what are you looking at? You're looking at the AHI, the apnea hypopnea index, and that tells you whether you have sleep apnea. It's the number of apneic and hypopneic events per hour of sleep. The apneas are caused the pauses of breathing, and this must last for 10 seconds to be associated with a decrease in the blood oxygenation. And this is what leads to your being able to diagnose. And this gives the overall sleep apneic severity score that you decide your treatment plans on. It's very simple, because and the best part about getting a PhD done is that they give you a readout. Okay, so here's what it is. You would get, these are the parameters that fall in line. If you have 0 to 5 events, it's normal. 5 to 15 is mild. 15 to 30 is moderate. Above 30 is severe. And that's where, if you look at mild to moderate, this is probably going to fall into the lines of an orthodontic evaluation. You may be able to do good. If it is beyond 30, you definitely need to refer the patient to a pulmonologist, start him on a CPAP, and then see whether you can, you can sort of downscale him from a CPAP to an oral appliance. There was a time when the only solution for sleep apneas was the CPAP. And before the CPAP, all you could do was a tracheostomy and hope that the patient survived it, right? But then I think the first change in the dimension of treatment on the obstructive sleep apneas came from the CPAP, and somewhere down the line, the advantages of the oral appliance therapy began to emerge. And this is, I think, some people are just not comfortable. I've had patients who say, I can't just use a CPAP machine. It makes me bloated. It pushes air because people do swallow air. And there are issues that happen with it. So this is the case, friends, ladies and gentlemen, for the oral appliances. And they have been investigated, they've been written about, and they're simple, silent, less invasive, bed partner friendly, and they have definitive benefits and outcomes. There are places where you can't use the CPAP, but you have appliances which are titratable and they do much better. We've graduated to customized appliances. And all that you do is something that we've done for 100 years. We've moved mandibles, we've expanded the maxilla, right? They increase the upper pharyngeal airway, and this seems to be related to the oxygen saturation. These are papers that have been published, and they've won awards, because I've shown this before, that you need to evaluate the mandibular position before you do extractions or lock in a mandible. Okay. Now, here is the challenge about growing the mandible. We've done it, for many, many years, because if you look at it in children, the first signs are seen a little early in life. And if you're looking at the morphometric features for obstructive sleep apnea and sleep disordered breathing, by 12 years, you'd see it. And this is where this conference covers a lot about postural issues, which I'm glad would fit into this, because there's a nasal airway, there is a craniocervical extension, there's a forward head posture, which does not happen in sleep. And this is where the whole sort of biologic concept of integrating everything into dentistry comes to the forefront. Great initiative. Because there is a issue of expanding the jaw, changing mandibular position, but you need to understand what is the impact. How will it change things? Let's take this young lad, constricted, had problems with bedwetting, snoring. The parents would say, well, he's old. And I asked this question with great embarrassment. I said, listen, it's not his fault. They wouldn't understand till we got the cephalogram and you start looking at his middle pharyngeal airway, and you looked at the hyoid bone position and you said there was something wrong. So we got him started, sort of expanded it, got his teeth into a position, then advanced the mandible, went the conventional way. And this was the change that we brought about. Now, the challenge here was that you should be in a position where the treatment permits you the forward movement of the mandible, so that you can directly influence the airway. Well, a lot changed for him. This is interesting because pediatric sleep apneas and the twin block, which we've used, it's been sort of, you expand the upper jaw, you bring the mandible forward. It does work. It does work. Except that we've now got conscious about it. But I think this is something that we've done, except when you're conscious that what you do would probably influence the airway and you need to be aware of it. This is what happens. It's like the nose, and the heart palate is the floor of the nose. And if there's a constriction there, you will have an airway resistance. So constricted maxillas and crossbites need to be treated as early as possible. This is the first step towards preventing issues there. We started looking at the fact that if you expand, how much of a difference would it really make at the floor of the nose level? Well, not much, because we did sort of the micro implant assisted sort of VARAMI, and we did a CBCT to see what is the actual effect on the floor of the nose. Would it change? And that's the results are before you. At a high level, you get very little, but you certainly get adequate amount of expansion for you to advance the mandible and reduce the airway resistance. So this is something that we've done. So what are the principles of oral appliance therapy? I think mandibular advancement is the key to widening the airway and providing relief. It's very simple. And you can see what the effects of the oral appliance are in the sagittal and in the actual relationship on the upper airway and the soft tissues, because it provides support and it prevents the airway from collapsing. We needed introspection because aesthetics are crucial. And as you grow adults, you may not be in a position to advance the mandible. And if you did, you do not want to bring in occlusal changes, which are going to compromise other issues for an adult. So we did experiment with, homemade incremental advancement devices, which, you gave it to about 60% of the advancement, and then you moved it ahead and you took a series of x-rays to see what is the impact on the airway. Complicated. But as I said, we did go on and we did come up with, I was lucky that we found a customized appliance, which I'll just talk about. And this is with nasal dilators, tongue filters. Well, this is all, a little bit of things on the side, but this is what happens. You can see on the left and the right, straight away, the hyoid bone position and the airway patency is changed when you give an appliance, right? So we started looking at customized appliances, which were rigid, which were from a single block. It's called prosomnus. And you don't want a vertical opening where it's going to compromise the TMJ. Yet you want to do about 60% of the advancement, which is possible. You register a bite on something called the George gauge, and then you get an appliance which holds the mandible forward. You get a series of appliances. The first one will about do 50% of the actual movement, and then the jaw gets used to it, and then you can move it. Now, this is where we've treated some adults. He's a planter. He had a big issue on snoring and traveling, and I was very concerned when I took him up for treatment, because I said, listen, he's got a good occlusion. I don't want to land up destroying it. But you can have a look. This is his sleep scale, and this is his polysomnographic report. And you can see his AHI index, which is given there, which is fairly substantial, which is enough. And we took a polyvinyl siloxane impression, we registered a bite, and we got a customized mandibular repositioning appliance. It's called Prosomnus from the US. We've done some research, we've published on it. And he was very comfortable because he could travel. He traveled a lot. So it brought him to a point where he could sort of do away with the CPAP when he was flying long distance at night, and he was quite comfortable with it. This is the change. And we were viewing the, sort of the appliance, and our concern certainly was the occlusion. But you can see here that the airway, his snoring stopped, and he's quite comfortable. And this is post-treatment, where we've not damaged the airway. So that's a huge issue for us. And that was a big thing. You can see whatever we've said about a flabby chin, about a big neck, this thing, and a huge BMI, and you can see the hyoid bone position and its distance from here. And you can see the airway here. You can see the airway was compromised in its position form, and that's how it is. So we did a polysomnography at the, after he'd worn the appliance for about 6 months, and we took a scale and found this. He's a young doctor who had a similar problem. And, I'm showing you these cases because our challenge was perfect occlusion. Now, how do you mess with a perfect occlusion? So we had to make sure that we got him a customized snore device, and then he wore it for sleeping. And, you had a huge change in the lower pharyngeal airway, and you can see the hyoid bone position. It's shortened, and, you can see that the airway has become teardrop shaped. That's what we do. So here's what it doesn't stop there, because there are cases where surgery is absolutely indicated and you need to do it. And what you need to do is that the airway can be divided into 3 anatomic sections for evaluation: the nose, the retropalatal area, the lateral pharyngeal walls, the retroglossal area, and the tongue. The retroglossal region is most influenced by the position of the mandible and the tongue. And mandible retrognathia will cause the base of the tongue to fall posteriorly during sleep and obstruct the airway, causing an obstructive sleep apnea. Oh, this was a difficult case. This young lad had not slept all his life except sitting up when he came into the clinic because he couldn't afford it. And at the institution, we looked at him. Just have a look at the severity of the problem and the complete compromise. Now, this is a classic case, and it was made worse by the fact that he had amelogenesis imperfecta. We couldn't put brackets on his teeth. So our first challenge was that before you do anything to the mandible, we got him on a CPAP, but then we said we need to expand the maxilla to be able to accommodate the mandible. So this is some innovation. We cast an appliance and we secured it with micro implants, and then we went on to do a expansion, and then we did a three-piece maxilla. We sort of expanded his upper arch, and then we started moving his mandible. So it went on. He's had about 8 surgeries. This young man, I want you to look at the flabbiness, look at the chin position. Anybody, you don't have to be an orthodontist. You just look at a face like that and you start looking at problems. And you can see a deep bite, a mandible locked back by an anterior tooth position, and he'd got sort of a whole lot of root canals done because somebody told him that's the solution to your problem, and a prosthodontist is going to raise your bite. Until he came to us and we said, listen, hello, he's got problems. He doesn't sleep well. You look at the dark rings around his eyes. So we evaluated him, and then we took him up for surgery, right? And that's what we did. We did a mandibular advancement with the intention of not just his mandible, but also in correcting his sleep apnea. And you can see that. You can see the change in the Hoyt bone position. You can see the change in the lower pharyngeal airway. What is the effect of moving the mandible and, changing it? Well, I'm sure people would say that this would have been done in any case, but the point is that for us, it was a larger issue of rehabilitating him biologically than just looking at, correcting teeth or doing this. These are more serious cases where you have no choice. But then a former student of mine, who's now a 2-star general, he's an expert in sleep apnea, and he shared these cases which were done where, major distraction was done to advance the mandible and create an environment where, the patient could sort of be rehabilitated and got them to sleep. So I'm just saying that some things may not be just within the purview of doing, oral appliances, and surgery certainly becomes important. This is the challenge. So I'm going to close this here, ladies and gentlemen. It is a silent epidemic, right? It's a multifactorial condition. It's you need to have an individualized diagnosis. You need to have a comprehensive medical and dental history. You need adjunctive diagnostics. We've gone to the point that you need to work with your other colleagues. But the challenge is that if you don't treat it, there are issues of sudden death, there's hypertension, and it also gives you an opportunity to position oral health sciences or dentistry back into mainstream healthcare, where your ability to modify the movable parts of the craniofacial skeleton will bring about a huge change in the biology of the patient and his recovery. Okay, so this is what we would say, that we have a primacy in management because of our ability to work with functional appliances, and you are adept at it. There are more than 120 appliances which would change the position of the mandible, right? I think it is certainly a great initiative, and I really must appreciate Dr. Marian and Professor Sam and Simona about this, creating a covenant of trust between dentistry, biomedicine, and systemic health. Because I tell you, technology and perfection trap and a dependency on just the most obvious elements of what the industry pushes at your face has come at a cost. We've drifted away from who we are, And what is the overall perspective of oral health in the whole business of healing and well-being? There is a value on diagnosis, and we certainly need to change the curricula. We need to look at knowledge and skills, and I think sustainability is going to come from our being able to change a few things here with challenge. And of course, my biggest worry now about sustainability is that this millions of kilograms of polymer which we are dishing out to our patients in aligners, the patients would probably go home and throw it in the rubbish bin. Where does it go? So, we need to think about sustainability. I'm going to close with this little quotation from Mark Twain, who says that the lie was halfway down the street while truth was still putting on trousers and getting out of bed. And I think we need to focus on the biology, sustainability, all the issues, and the lovely presentations to follow in this series of lectures. I think it's a great initiative. Thank you so much. I must thank the organizers, Professor Marian, Simona, Professor Sam, for giving me this opportunity. Your questions are welcome. Write to me, communicate with me. We do practice sleep medicine. I do it at my level, but at the institution level, we certainly screen everyone and we do what we can. Thank you so much, and God bless you. And